Hello there and welcome once again to The Verdict. I'm Mick Cornett. Kent Myers is out this week, but he'll be back with us next week. In this show, we're going to learn more about congenital heart disease. The director of the newly formed Adult Congenital Heart Disease Clinic for OU Medicine will be our guest, and we'll get to it right after this break on The Verdict.
What I can offer is insight into understanding the Native American art, how these artists are expressing themselves as cultural people. I am Heather Ottone. I'm a Native American researcher and curator, and I am Chickasaw. I can remember in first grade the teacher saying, "Well, you're so lucky you don't look Indian." That was difficult to hear because it was what I was. It's what I am. I think there's a renaissance going on amongst the tribes. I think the Chickasaws are leading that. We didn't die. We're not gone. So what are we now? And what can we do now to start to form that identity, to survive into another century? And to have the culture guiding us into that future, that would be significant.
See more stories about the Chickasaw people at profilesofanation.com.
Welcome back to the set of The Verdict. Thank you for joining us today. And our guest in this show is going to be Dr. Sabrina Phillips. She is a medical doctor for OU Medicine, and she has quite an interesting history. Actually, grew up in Oklahoma, in the Tulsa area. Got your undergraduate degree in Wichita State University in the electrical engineering department. Then went to medical school in Dallas. Wound up working and becoming certified at the Mayo Clinic. And I'm condensing a great number of years here, I know, but then you have wound up down at OU Medicine, and you have formed the new Congenital Heart Disease Clinic at OU Medicine.
Correct.
That's quite a task. Now, when you were growing up as a girl in Oklahoma, I guess in Cleveland,
yes,
actually where you were growing up, you probably didn't think, I want to be a doctor dealing with congenital medicine. How did you get there? What was the path and the surprises along the way?
Well, as you can imagine, the path is never straightforward as we find our way in life. But I did really want to be a physician, even from the time I was a fairly small child. And
now,
I think
why was that? Was there someone in your life that was a doctor that you wanted to emulate?
No, but my mother was a fantastic role model for caring for people. And she did a lot in our family and our extended family to help make sure people got to their doctor's appointments, understood what happened at the doctor's appointment and what their follow-up should be. And I can remember as I went with her to these many appointments with grandmothers and aunts, I would think, I wonder what's happening behind that door. What happens when they go in the office? Because it was clearly a big event for people to plan for this appointment. It changed maybe their life or their lifestyle after the appointment. So I felt it was very important whatever happened behind that doctor's office door. And I was very fascinated with that aspect and wanted to learn more about medicine. Though I did get a degree in engineering, I think because I like to think about how things work. And that was I love science and math, and finding out how things work and exploring that was great. And
well, even when you were getting that electrical engineering degree at Wichita State, were you still planning to be a doctor?
No, I had kind of thought, well, I didn't really understand completely the path to getting into medical school and following through with that. So I did understand how to get a bachelor's degree and move forward there. And so I just sort of leveraged all that science and math interest into engineering. But as I got out, I actually worked for a few years at Texas Instruments with my engineering degree, and sort of was able to mature enough and realize, hey, I can go forward. I can take these steps to go to medical school and all that entails to get to be a doctor, which is clearly what I really wanted.
How many years from that date until you wound up as a doctor?
So by the time I graduated from college till I went to medical school was 3 years. So I had a little hiatus there.
Yeah, and how many years in medical school?
So 4 years of medical school, and then 3 years of internal medicine residency, 3 years of cardiology fellowship, and then a year of sub-fellowship for congenital heart disease.
Now, when you first entered medical school, were you thinking that heart disease or cardiovascular was an area that you were interested in, or did that develop during those 4 years?
It really developed. I kind of came into medical school with a very open mind. I had no preconceived notions about, oh, I'm going to be a surgeon or I'm going to be this type of physician. And I really just loved every moment of medical school. I knew from almost day one that I had made the right choice, that this fit me. And I really enjoyed learning about all specialties, from psychiatry to OB to surgery. But it really was my last year of medical school. I did a rotation in a pediatric cardiology office setting. And I thought, wow, I really think this is interesting, how this heart disease in children works, this congenital heart disease.
Right.
But I knew that I wanted to be an adult physician. And luckily, as so many things in life are, I had a good mentor that was right there. And this was Dave Fixler, who's the chief of pediatric cardiology in Dallas. He said, you know, we need adult cardiologists who are specialty trained to take care of folks with congenital heart disease. This is a big need. And he really opened my eyes to what's out there and what we needed to do. And I then pursued the sub-fellowship later as I went through medicine and cardiology.
Because most people with heart disease, it's the result of life choices and actions that they've taken.
Correct.
And congenital heart disease is something you inherit from your two parents.
Right. It's congenital heart disease is a defect in the cardiac structure or function from the time the heart is formed. And it can be somewhat simple, straightforward defect like a small hole between the top chambers of the heart, or it can be very complicated, involving poor development of one or more of the chambers so that you don't have a fully functioning cardiovascular system. And so that only affects about 1 in 100 babies, but that's actually not a small number when you think about all the babies born. And so with the advancements in cardiac surgical care to care for very complicated forms of heart disease, to advances in medical care that help people deal with the sequelae or the consequences, we have now had amazing improvements in survival. So today, if you're born even with very complicated heart disease, if you live to your first birthday, there's an 80% chance you'll be an adult that needs to be seen.
We've come a long way then, haven't we?
A very long way.
And how is all that detected? I mean, when a newborn baby comes into the world, how does a pediatrician or someone suspect that they may be an issue with the heart?
Well, there's several things that could draw attention to the baby. Sometimes even when the baby's still in the uterus, if they're doing an ultrasound scan of the baby, we can see the baby's heart, and there are some features that trigger concern that there's a defect then. So some babies we know even before they're born. Oftentimes right after the baby is born, we note that they don't pink up. So they stay blue, meaning that there's getting unoxygenated blood into their systemic circulation. And so often that being a blue baby is an indication. Sometimes the baby's pink and looks good and healthy, but the doctor hears a sound, a murmur. That's fast flowing blood through the heart. And that could be a normal sound, or it could indicate a problem. And so then usually if there's suspicion of a problem, most likely we nowadays diagnose the heart defect with ultrasound. So sound wave test of the heart, and sometimes we augment that with other imaging like MRI, occasionally CT, and cardiac catheterization, where we directly put catheters into the heart to look at that.
And I guess it gets more complicated. I assume there's a lot of adults that might have a congenital issue, but they have no idea. Correct.
There are adults who have never been previously diagnosed with their congenital defect until something happens in adulthood that triggers an evaluation. And often that defect is not as dire as what we were talking about with not developing like a chamber of the heart, but it can still have serious consequences. But sometimes we will see adults who have very serious heart disease from birth that have never been picked up. So we see the spectrum. But the interesting thing with congenital heart disease, while we've made these great strides in treatment, unfortunately, none of our treatments are a cure. So even the best surgery can still leave you with long-term consequences. So the vast majority of people who are born with a heart defect, even with a good repair, need at least periodic evaluation in a center that has expertise or subspecialty training to take care of them.
Might the patient have limitations as well?
Yes, it depends on the defect. Some patients are fully functioning and can do all they want to do, including even participate in high-level sporting activities. But some patients are really more limited and may have heart failure symptoms, meaning they feel tired or have shortness of breath when they try to exercise.
Are transplants more likely in a congenital issue or an issue that was the result of life decisions?
Right. Well, if we looked at total numbers of transplants performed, it would be mainly performed for acquired heart disease, so lifestyle choices or bad luck, bad genetics with how you handle cholesterol and things like that. But that's the numbers because there's more people that have that.
Right.
If you look at patients who have acquired heart disease who need transplant versus those who have congenital, the percentage is smaller if you acquire heart disease that you would need a transplant than if you had congenital. Right now, though, it really is a very tough area for my patients to get transplanted because often they have maybe multi-organ disease, they may have some lung issues or even liver issues, and that's a real challenge for the transplant community to think about multi-organ transplant. So it is a real hard road for folks with congenital heart disease who have advanced to needing transplant to really find those options.
Yeah, but in heart disease that's caused by life choices, it seems like there's a few categories of resolution. You put in stents or you do something to try and get the flow going again. When you're talking about congenital, are there a handful of cases that you see over and over again, or is every patient different?
Well, all patients are slightly different, but there are certainly groups of patients that we see more frequently and conditions that we see more commonly as a consequence of their early repair. For instance, one of the fairly complicated forms of congenital heart disease is called tetralogy of Fallot, and that's been very nicely repaired surgically since the mid-1960s. But those patients, unfortunately, often have a leakage of one of their valves that's very significant. So I would say of operations done in most congenital heart disease centers, replacement of that valve for that condition is something we do see over and over. But each patient has a little bit unique anatomy that we have to evaluate and make sure we're doing the right thing for the patient before moving forward.
Dr. Sabrina Phillips is with OU Medicine. We're talking about congenital heart disease. We'll have more with Dr. Phillips after this.
The land to us is how we make our living. It's not an easy life. This land that OERB restored for me had pump jack stands, it had old building foundations with pipes sticking out of them. I could never have been able to afford to do these improvements like OERB did. They didn't just come out and put a Band-Aid on it. It's back to the prairie.
The good life comes naturally to Tulsa, where nature's beauty is matched with an eye for aesthetics. A legacy of neighborhoods graced with lawns and landscaping and handsome homes. A place that seems to have patented an ideal lifestyle. Bank First is loyal to the quality of life Tulsa assures its citizens, to the priority placed on education, culture, and growth. Loyal to builders who transform raw land into residential charm. Developers who see opportunity and add vitality to Tulsa's economy. Bank First serves both enterprise and private lives that need a loyal partner. It's how we help nurture this city's very good life. Bank First. Loyal to Oklahoma. Loyal to you.
Welcome back to the set of The Verdict. Our guest is Dr. Sabrina Phillips. She's a medical doctor with OU Medicine in the field of congenital heart disease. At what age do most patients determine that they have some sort of congenital issue?
It really depends on how severe the anomaly is with the heart, and some babies are diagnosed on hospital day one, right after they're born, and others are diagnosed later in life. The average, it's usually in childhood that we see the diagnosis being made.
Once, if a person is diagnosed in childhood and they, survive into adulthood, at what point do they hand off from one doctor to another? If you deal largely with adults, at some point there has to be a transition period.
That's a great question, and that's a really key point to providing good care for this unique patient population, is making sure we have a smooth transition from pediatric cardiology to adult congenital cardiology. And ideally, we work together. We're not two separate entities, but a team. And that usually in mid-teenage years, if I can meet with the patient while they're still seeing their pediatric cardiologist, where they have this great relationship, and then I can start building a relationship, that's usually the best transition. And then by the time they're 18, they're seeing me in clinic and not their pediatric cardiologist. But the transitions are varied, and because there's so few adult congenital heart disease subspecialists in cardiology, often these patients are continued to be cared for by pediatric cardiologists. But that's a real challenge, not because the pediatric cardiologists aren't great. They're fantastic at the care for these patients. But when you look at the numbers, there are now more adults in the U.S. with congenital heart defects that need care than children under 18.
Oh my. Huh.
So we could overwhelm the whole pediatric cardiology profession with our adult patients, and that's why it's so critical that we have a good collaboration and develop centers to care for these patients.
Medicine becomes more and more specialized. Do I take it that OU Medicine is trying to develop a specialty around these subjects?
Yes, and that's very important for a very large segment of the population. We really don't or haven't had a regional center that specializes in congenital heart disease. There are certainly physicians who've done a great job taking care of patients with congenital heart disease in the area, but when you look at all the components that provide the best care, the American College of Cardiology has actually laid out guidelines to how do we best provide care for these patients. And their vision is regional centers that have collaborative efforts with pediatric cardiology, adult cardiology subspecialties, including transplantation, and then other specialties, kidney doctors and liver doctors. And so OU Medicine is really in a good position to hopefully develop a full range of services to really meet the needs of this unique population.
Since you've been in practice, have there been breakthroughs on the technology side and discoveries?
Definitely. I mean, we have, breakthroughs aren't always make the front page of the Wall Street Journal, but still have a huge impact. And sometimes we learn that a certain medicine works very well, and maybe it's a medicine that's been already developed, or we get a new medication that was used in adult cardiology for another use, and we realize that it has great benefit in our patients. So I think that we have seen, just in the last 10 years that I've been in practice, a marked improvement in what we can do with medications, and we also continue to develop new strategies in the cath lab to help these patients live better, healthier lives, and our surgical techniques get better. So that impacts not just the babies that are being born and operated so that they do better into adulthood, but it really helps my adult patients who often need repeat surgeries.
What sort of research and development is going on now? Where do you see the industry headed?
Well, I think that we have several lines of research that can be of great benefit to the congenital heart disease population. First is some of the stem cell research, and that's gotten a lot of press in heart attacks or acquired heart disease, and could we regenerate muscle. But even here at OU, we're participating in some work with hypoplastic left heart, where you don't develop a left ventricle, and we're looking in collaboration with groups at Mayo and elsewhere, what can we do with stem cell injection to help the heart maybe recover or cope. Not necessarily grow a new heart, that's a little, I think, still out there and not really on the foreseeable horizon, though that would be quite interesting if we could take stem cells and grow a new heart for the patient. I think that's not going to be in the near future, but certainly we might get some impact with that. The other lines of research and treatment that I think are really expanding the options for our patients are all the great developments in ventricular assist devices. So these are mechanical devices that help pump blood around the heart to support the circulation. And those have traditionally been used in patients who have poor heart muscle function after heart attack or developing dysfunction maybe because of a virus. But we're using that and expanding that technique in congenital heart disease. And I think we're just going to get better and better as that technology improves. And we're going to have many more options for our patients, hopefully to avoid transplantation and all the difficulties with that.
Are there different parts of the world that seem to have more congenital heart issues than others? Are there certain gene pools that seem to be more reliant?
There are certain gene pools that where we will see certain defects pop up more frequently, but really congenital heart disease is seen in all cultures, Western and non-Western civilizations, and developed countries and undeveloped countries. So it really is an equal opportunity afflictor of babies, and so it's so important that we develop good care models for them and good care models for how to reach out to every population and provide care.
Where are most of your patients coming from when you see them for the first time? Is it from Oklahoma City or the state or the region, or is it larger than that?
It's a mix, and right now we certainly are seeing local patients and patients from the Oklahoma area, not just Oklahoma City, but Tulsa and surrounding communities. But because there are so few regional centers, over the years in practice we tend to develop a grouping of patients that may stay attached to a physician. So currently we have patients seeing me from Texas, from Minnesota, Indiana, people that I've seen, in the past, but they want to continue with a regional center. So hopefully as we develop more expertise and a more comprehensive center here, we'll be able to draw in from the whole region and serve the population well.
Are we seeing more and more doctors enter this field, or is this still a field that gets overlooked by a lot of medical students?
It's still relatively low numbers of people who pursue it, though we are seeing more and more interest. And this year we've become a recognized subspecialty in cardiology with our own board exam. So for the first time ever this month, we're going to offer a board certification exam in congenital heart disease. So that will set apart providers who have received expertise and subspecialty training to help patients understand who might serve them best.
Right. You grew up in rural Oklahoma. You might have opinions on the way we look at it now. There's just not enough doctors who are willing to serve in these rural areas. What advice do you have for the state as it tries to figure this out?
Right. I think that underserved populations, whether it's inner city or rural, are a special need group, and we need to continue to encourage medical students to pursue their passion. And I feel like even though I'm practicing now in the city, I think that still reaches out to the rural population. I think if you can get here and we can serve you, that's a good thing. So you don't necessarily have to practice in that small community to have an impact. And I think that's a good thing to remember, is you can go back to your region and still impact your community, and that's a good thing.
Right. Somebody might be watching this show and they themselves or somebody they know has wondered if they have some sort of a heart issue. What should they do?
Yeah, so the best thing to do is have a good physical exam with your primary care physician. Make sure there are no abnormal sounds detected when they listen with the stethoscope. Make sure your blood pressure is under good control. And then if there is a concern after a good physical exam, they can be referred to cardiology for an ultrasound test or an echocardiogram, which is a very good diagnostic tool to look at the heart and its function.
When you go to family reunions, do people want a free checkup or anything like that? Do you run into people wanting free medical advice?
On occasion, though I have the opposite. My own daughter often will tell me some symptom, and then I'll say, well, I think that could be, and she'll say, you're a heart doctor, you're not a whatever. So, it goes both ways.
I'm sure it does. Dr. Sabrina Phillips, thanks so much for joining us on The
Thank
Verdict.
you.
She's with OU Medicine. I'll have a final word when we get back.
There are now 11 million of us who live here and work here. I was 15 when I came here 6 years ago. I raised my family here. I drive my truck to my job every day. The only difference between now and 6 years ago, I do it legally. I wanted to. Because this is my home.
All children deserve a life of hope and love, but sometimes they experience a life of pain, neglect, and abuse.
When that happens, each child deserves all the quality assistance and representation that can be offered in our legal system. For more information, call 23-CHILD.
Oklahoma Lawyers for Children, helping to bring hope and love back to the lives of abused children.
You will always be Mom and Dad to me.
I really think people are so unaware of the number of kids waiting just in Oklahoma. And I think if more people knew that those children were out there waiting, I think that just by the way we live our lives and the people we talk to, that maybe we can help encourage adoption from Oklahoma.
You will always be Mom and Dad to me.
The Journal-Record is pleased to be a sponsor of The Verdict. The Journal-Record, since 1903, the best source of Oklahoma business news and legal information.
And for almost 30 years, Oklahoma political, government, and business leaders have turned to the McCarville Report for accurate, reliable, inside information. Visit the McCarville Report online.
Welcome back to the set of The Verdict. We are wrapping up a show with the director of the newly formed Adult Congenital Heart Disease Clinic at OU Medicine. Her name was Dr. Sabrina Phillips, and really exposed me to the different aspects of heart disease. And the one we focus the most on is the one we have the most control over. We know about high cholesterol and heart disease that develops as an adult. But to take on the task of congenital heart disease, which usually starts with young children and then advances into adulthood, is a completely new field, and we appreciate her coming on the show and exposing the differences. We have some website information. You can find out more information about her work at oumedicine.com. That's oumedicine.com. And we have a website. Love for you to go there and tell us about a show you'd like to see on an upcoming edition of The Verdict. Our website is theverdict.tv. That'll do it. Kent will join me next week right here on The Verdict.